Good day, everyone. We are BSN 2D Group 2 and we will be presenting alterations in endocrine function, alterations in skin integrity, child abuse, and violence in the family. We are the Group 2, Miss Bispo, Mr. Ko, Miss Dinoy, Miss Dumapias, Miss Layson, Miss Longakit, Miss Paco, Mr. Roma, Mr. Sal, Miss Tabuco, and Miss Villafuerte. The contents under alterations in endocrine function includes disorders of pituitary function, disorders of adrenal function, disorders related to sex chromosomes abnormalities, and inborn errors of metabolism. The contents under alterations in skin integrity includes dermatitis and infectious disorders. And under child abuse and violence in the family are different theories of child abuse. Let's start with the alterations in endocrine function. Hello everyone, I'm Miss Layson and I'll be discussing the growth hormone deficiency. So let's start with the definition. So this is also known as dwarfism or pituitary dwarfism, a condition caused by insufficient amounts of growth hormone in the body. The causes can either be congenital or acquired. So under congenital, first is damage to the pituitary gland or hypothalamus that may be the result of an abnormal formation that occurred before the child was born. So the disease was already there when the child was born. Another is mutation in genes for factors that are important in pituitary gland development or in the receptors and factors that includes the growth hormone or along the growth hormone pathway. To date, however, the causes of these mutation in genes are still unknown. Under acquired, it can be caused by a brain tumor in the hypothalamus or pituitary, head trauma injury, radiation therapy for cancers if the treatment field includes the hypothalamus and pituitary gland, disease that infiltrate the hypothalamus or its connection to the pituitary gland such as histiocytosis. And lastly, an autoimmune condition like lymphocytic hypophysitis. This is a condition in the pituitary gland wherein the pituitary gland becomes infiltrated by lymphocytes. There are different types of growth hormone deficiency. Isolated growth hormone deficiency is caused by mutations in one of at least 3 genes. The first type of growth hormone deficiency is the isolated growth hormone deficiency type 1A. This is caused by an absence of growth hormone and is the most severe of all types. In people with type 1A, growth failure is evident in infancy as affected babies are shorter than normal at birth. Isolated growth hormone deficiency is caused by mutation in the GH1 gene. Remember that GH1 gene provides instructions for the making of growth hormone protein. The second type is the isolated growth hormone deficiency type 1B. This is the production of very low levels of growth hormone. As a result, type 1B is characterized by short stature, but this growth failure is typically not as severe as in type 1A. Growth failure in people with type 1B is usually apparent in early to mid-childhood. So this is caused by the mutations in either the GH1 or GHRHR gene. So the GHRHR gene provides instructions for making the growth hormone releasing hormone receptor. The next type is isolated growth hormone deficiency type 2. So type 2 have very low levels of growth hormone and short stature that varies in severity. Growth failure in these individuals is usually also evident in early to mid-childhood. It is estimated that nearly half of the individuals with type 2 have underdevelopment of the pituitary gland. So this is also caused by the mutation in the GH1 gene. So the last type is the isolated growth hormone deficiency type 3. So type 3 is similar to type 2 in that affected individuals have very low levels of growth hormone and short stature that varies in severity. However, this is caused by the mutations in the BTK gene. So the BTK gene provides instructions for making a protein called Bruton tyrosine kinase, which is essential for the development and mutation of B cells. B cells are specialized white blood cells that help protect the body against infection. This is why individuals with isolated growth hormone deficiency type 3 have weakened immune system and are prone to frequent infections because they produce very few B cells and have a shortage of antibodies. A lack of the BTK protein is likely responsible for the immune system symptoms, but how a shortage of BTK protein causes short stature in affected individual is still unclear. Let's read the disease process of growth hormone deficiency. Growth hormone helps children to grow to their full height potential. Hence, they need adequate amounts of growth hormone. The hypothalamus secretes growth hormone stimulating hormone. Then the release of GHSH stimulates the anterior pituitary gland to stimulate somatropin to release growth hormone into the bloodstream. Cancer treatments such as radiation or surgical procedures to structures in the head or brain, congenital damages of the pituitary gland, mutation in genes that affect pituitary gland development, etc., may cause the glands that control growth to malfunction. As a result, the pituitary gland may not make enough growth hormone, resulting in growth hormone deficiency. The following are risk factors of growth hormone deficiency. Cancer treatment before reaching adult height, especially if the person is too young. Radiation to the head or brain. Total body irradiation or TBI. Surgery to the brain, especially the central region of the brain where the pituitary gland is located. All these factors can potentially affect the function of the pituitary gland that could later on cause the deficiency in production of growth hormone. Signs and symptoms. So the common ones are slow growth or absence of growth, short stature but proportional height and weight, absent or delayed sexual development during puberty, and headache. Other symptoms of pituitary hormone deficiency that may coexist with growth hormone deficiency. One is increased urination and amount of urine, excessive thirst, and facial abnormalities. The diagnostic tests includes physical examination. In addition to thorough medical history, the physician may measure the height, weight, arms, and leg lengths of the client. Another is blood test. This is used to measure the levels of growth hormone in the body as well as the levels of other hormones. And lastly are imaging tests, which includes X-rays and MRI of the head, can be helpful in narrowing down the underlying disorder causing GHD by revealing abnormalities of the hypothalamus or the pituitary gland. The first nursing diagnosis is disturbed body image related to psychosocial as evidenced by statements of fear of reaction by others. Clients with congenital or acquired GHD tend to have problems with how they look, especially when around peers. The second nursing diagnosis is risk for disproportionate growth related to dysfunctional endocrine gland. Anomalies of the hypothalamus or anterior pituitary gland could result in GHD that may interfere with normal growth and development. The last nursing diagnosis is situational self-esteem related to disturbed body image as evidenced by reports of current situational challenge to self-worth. Children with dwarfism experience infantile among peers inside or outside home that could affect their self-esteem. Management of growth hormone deficiency. Under nursing management, the nursing interventions. The nurse must educate the client on what GHD is, its causes, its management, and possible side effects of the management. Educating the client eases anxiety and gains cooperation from the client. The nurse must assist with diagnostic tests and prepare the child and family for a number of tests to be performed. Assisting with diagnostic tests helps the nurse formulate an accurate diagnosis. Observe for signs of hypoglycemia. Hypoglycemia can occur due to tests with insulin or arginine. And lastly, monitor the progress of treatment. Monitoring the progress of treatment helps facilitate improvement. Monitoring is also a continual support for the client. Medical interventions. X-rays. The patient will have X-rays done so that growth hormone and bone age can be monitored. Patients who are advised to take pharmacologic agents must stop treatment prior to epiphyseal closure. Blood samples. This is used to measure the levels of growth hormone in the body as well as the levels of other hormones. For pharmacological intervention, the use of somatropin. This is used for growth hormone deficiency because it is similar to naturally occurring growth hormone. It stimulates growth and protein synthesis. This slide and the following slide is the pathophysiology. It shows the risk factors, etiology, disease process, signs and symptoms, managements, which we already discussed earlier. So I'll be reading the nursing care plan. So the first column, the needs, problems, and cues. So this is a physiologic deficit, disturbed body image. Objective cues, short stature, increased urination, behaviors of acknowledgement of one's body. For the subjective cues, slow growth as verbalized by the child's parent, statement of fear of rejection by others, reports of headaches, expression of negative feelings about body. The nursing diagnosis, disturbed body image related to psychosocial as evidenced by statements of fear of reaction by others. Scientific basis. The way in which our experiences and environment affect our body image will differ for everyone. However, overall, the research suggests that body image can be influenced by relationships with family and friends, how the family and peers feel and speak about bodies and appearance, exposure to images of idealized or unrealistic bodies through media or social media, pressure to look a certain way or to match an ideal body type. Most of these bring fear to people who are different and unique. For the objectives of care, general objective, after a week of holistic nurse-patient interaction, the client will be able to display acceptance of self as evidenced by recognition and incorporation of the actual body in an accurate manner without negating self-esteem. Specific objectives. After 8 hours of student-nurse-patient interaction, the patient will be able to verbalize acceptance of self, relief of anxiety, and adaptation on actual body image. Second, acknowledge self as an individual who has a responsibility for self. Third, discuss feelings and recognize a realistic expectations throughout the treatment. Nursing interventions. Measures to attain self-acceptance. First, educate the child and the family on the causes, effects, and management of growth hormone deficiency. Knowledge will empower and ease the family and the child's anxiety. Second, educate and prepare the child and family for a number of tests to be performed. This is to enlighten the child and the family on the test to be performed, the importance of the test, and the possible side effects. Child also requires particular attention during growth hormone stimulation testing. Third, administer somatropin as prescribed to assist in correcting underlying conditions that is causing disturbed body image. Somatropin is used for growth hormone deficiency because it is similar to naturally occurring growth hormone. It stimulates growth and protein synthesis. Fourth, provide assistance in setting realistic expectations regarding improvement. Even when hormone replacement is successful, these children attain their eventual adult height at a slower rate than their peers. Affirm clients' justified feelings such as anger or guilt, and emphasis on the treatment plan and prospects for improvement in the future. The client's feeling is important. Acknowledging the client and the family's feelings also help build a good relationship between the nurse and the client. Encourage family members to treat the patient normally and not as an invalid. This helps empower the client and helps build self-esteem. Refer a counseling psychologist for children diagnosed with idiopathic short stature, whether done in conjunction with growth hormone therapy or treatment. Counseling psychologists help people with physical, emotional, and mental health issues, improving their sense of well being, alleviate feelings of distress, and resolve crisis. Special counseling is to be given to children having problems in school. These children appear younger than their chronological age. Peers may frequently relate to them in infantile or childish ways that could greatly affect their self-esteem. Professionals and families may find research, education, support, and advocacy from the Human Growth Foundation. Treatment to help in the improvement of growth development could be expensive. The Human Growth Foundation helps clients and families with growth and bone disorders. The last nursing intervention is to refer to appropriate support groups. This helps the child and the family know that they are not alone. Evaluation. After a week of student nurse patient interaction, the client was able to display self acceptance by recognizing and incorporating his actual body image in an accurate manner without negating himself. Hyperthyroidism. Definition. This is defined as an overactive thyroid. This is also known as thyrotoxicosis. This is where the thyroid gland produces too much of the thyroid hormones. Etiology of hyperthyroidism. The most common cause of hyperthyroidism is Graves' disease. This disease runs in families and is autoimmune. The hyperthyroidism of Graves' disease is caused by the generation of autoantibodies to the thyroid stimulating hormone receptor. This leads to excess secretion of thyroid hormone. Other causes includes excess iodine. This is a key ingredient in T4 and T3. Another is thyroiditis or inflammation of the thyroid, which causes T4 and T3 to leak out of the gland. Another are tumors of the ovaries or testes, then benign tumors of the thyroid or pituitary gland, and large amounts of tetraiodothyronine taken through dietary supplements or medications. Disease process of hyperthyroidism. So the hypothalamus secretes thyrotropin-releasing hormone, which in turn stimulates the pituitary gland to produce thyroid-stimulating hormone. This hormone stimulates the production of the thyroid hormones, thyroxine and triiodothyronine by the thyroid gland. Unfortunately, some treatments given for childhood cancer can damage the endocrine system, resulting in a variety of problems. One of these problems is hyperthyroidism, an overactive thyroid. It occurs when your thyroid gland produces too much of the hormone thyroxine. Thyroxine plays vital roles in digestion, heart and muscle function, brain development, and maintenance of bones. Hyperthyroidism can accelerate your body's metabolism, causing unintentional weight loss and a rapid or irregular heartbeats. Who are at risk of hyperthyroidism? So first, women are 5 to 10 times more likely than men to develop hyperthyroidism. It is suspected that the development of hyperthyroidism and its variants is linked to autoimmunity, which is more commonly found in women than in men. Clients who have had a thyroid problem before, such as goiter or thyroid surgery. Clients who have pernicious anemia. type 1 diabetes or primary adrenal insufficiency, a hormonal disorder, clients who have a family history of thyroid disease, clients who eat large amounts of food containing iodine, such as kelp, or use iodine-containing medications such as amiodarone, a heart medication, clients who are older than 60 years old, and clients who have been pregnant or delivered a baby within the past 6 months. Signs and symptoms. The common signs and symptoms are high metabolic rate, frequent bowel movements, weight loss, irregular menstrual cycles in women. Visibly, the thyroid gland itself can swell into a goiter, which can be either symmetrical or one-sided. Eyes may also appear quite prominent, which is a sign of exophthalmos and a condition that's related to Graves' disease. So under high metabolic rate, the client may experience a rapid heart rate, elevated blood pressure, and hand tremors. Other symptoms of hyperthyroidism include increased appetite, nervousness, restlessness, inability to concentrate, weakness, irregular heartbeat, difficulty sleeping, fine brittle hair, itching, hair loss, nausea and vomiting, and breast development in men. The following symptoms require immediate medical attention: dizziness, shortness of breath, loss of consciousness, and fast, irregular heart rate. Diagnostic tests include thyroid stimulating hormone test. The ultrasensitive TSH test will probably be the first test your doctor performs. This test can detect even tiny amounts of TSH in the blood and is the most accurate measure of thyroid activity available. The TSH test is especially useful in detecting mild hyperthyroidism. Another is the T3 and T4 test. This test will show the levels of T3 and T4 in the blood. If you have hyperthyroidism, the levels of one or both of these hormones in your blood will be higher than normal. Next is thyroid stimulating immunoglobulin test. This test, also called a thyroid stimulating antibody test, this measures the level of TSI in the blood. Another test is the radioactive iodine uptake test. The radioactive iodine uptake test measures the amount of iodine the thyroid collects from the bloodstream. Measuring the amount of iodine in the thyroid will help doctors know what is causing hyperthyroidism. The last test is the thyroid scan. A thyroid scan can show how and where iodine is distributed in the thyroid. This information helps doctors diagnose the cause of hyperthyroidism by providing images of nodules and other possible thyroid irregularities. Here are 3 nursing diagnoses. First is deficient knowledge related to unfamiliarity with information resources as evidenced by inaccurate follow-through of instruction. Knowledge plays an influential and significant part of a patient's life and recovery. Nurses get in the manner of offering patient education as a way of providing nursing care to obtain the best outcomes for their patients. Second is risk for decreased cardiac output related to uncontrolled hyperthyroidism. Hyperthyroidism causes high cardiac output and left ventricular hypertrophy in the early stage, and by ventricular dilatation and congestive heart failure in the late stage. And the third nursing diagnosis is fatigue related to hypermetabolic state with increased energy requirements as evidenced by verbalization of overwhelming lack of energy to maintain the usual routine. Since hyperthyroidism increases your metabolism, many individuals initially have a lot of energy. However, as the hyperthyroidism continues, the body tends to break down, so being tired is very common. This slide and the following slide are the managements. For the nursing management, nursing interventions, The nurse can help parents understand the medical reason for behavior changes and offer ways to minimize them. This helps the parents and the child cope with different changes that they may undergo with the disease. The nurse can advise the parents to have consultation with the child's teacher. This is to provide education and suggest ways of helping the child adjust at school. The nurse may advise that the client should use light cotton clothing at home, good ventilation, air conditioning or fans, frequent baths, and adequate hydration. The client may experience heat tolerance, hence, the advice mentioned can help provide comfort. Nurses should know the side effects of ATD therapy. Knowing the side effects and being able to distinguish serious side effects would help the nurse recognize when to stop administering the medications. Lastly, the nurse should explain that the throat is not cut, only the skin, in removing the gland. This eases the fear of having one's throat cut. Under medical interventions, measure the thyroid-stimulating hormone, free thyroxine, and the total triiodothyronine levels. This determines the presence and severity of the condition, as well as radioactive iodine uptake and scan of the thyroid gland to determine the cause. Let the client receive a radioactive iodine uptake test. This measures the amount of iodine the thyroid collects from the bloodstream. And lastly, do not routinely order a thyroid ultrasound in patients with abnormal thyroid function tests if there is no palpable abnormality of the thyroid gland. The reason behind this is that overzealous use of ultrasound will frequently identify nodules which are unrelated to the abnormal thyroid function and may divert the clinical evaluation to assess the nodules rather than the thyroid dysfunction. This may lead to further unnecessary investigation, unwarranted patient anxiety, and increased costs. So here is the pathophysiology of hyperthyroidism, the factors, the etiology, the disease process. We already discussed all these a while ago, which is followed by the signs and symptoms and the managements, which we also already discussed. So now I'll be reading the nursing care plan for hyperthyroidism. So under the first column for the needs, problems, and cues, we have a physiologic deficit, which is deficient knowledge. The objective cues are inaccurate follow-through of instruction, altered heart rate, jittery behaviorism, and confused face. So under subjective cues, we have request for information as to why the child is wearing clothes differently, verbalization of fear that a child may have the throat cut, and reports on sudden episodes of crying. Nursing diagnosis, deficient knowledge related to unfamiliarity with information resources as evidenced by inaccurate follow-through of instruction. For the scientific basis that will support our nursing diagnosis, knowledge plays an influential and significant part of a patient's life and recovery. Nurses get the manner of offering patient education as a way of providing nursing care to obtain the best outcomes for their patients. Patient education should always be made available in the healthcare setting. A patient is considered most effective when information is accessible whenever it is needed. For the objectives of care, general objectives. After a week of holistic student-nurse-patient interaction, the client will be able to understand and practice correct and sufficient management of hyperthyroidism. Specific objectives. After 8 hours of student-nurse-patient interaction, the patient will be able to verbalize understanding of disease process and potential complications, identify signs or symptoms, and correlate symptoms with causative factors. Nursing interventions, measures to understand and practice correct and sufficient knowledge on the management of hyperthyroidism. First, review the disease process and future expectations. This provides a knowledge base from which the parents of the patient can make informed choices. Advise parents to have consultations with the child's teachers. The child experiences behavioral changes such as irritability that may disrupt interpersonal relationships, create difficulties within and outside the home. Hence, consultation with a child's teacher is important to provide education and suggest ways of helping the child adjust in school. Third is to instruct parents to let the child use light cotton clothing at home, to let the child have good ventilation, air conditionings or fans, frequent baths, and adequate hydration. This is because heat intolerance can cause the child to dress differently, and all these mentioned can promote comfort to the child. Fourth is to educate parents on the healthy way of increasing calorie intake. Although the need for calories is increased, they should be provided in wholesome foods rather than junk foods. Fifth is to let the parents be aware of the signs of hypothyroidism, which can occur from overdose of drugs. The most common indications are lethargy and somnolence. So a patient who has been treated for hyperthyroidism needs to be aware of the possible development of hypothyroidism, which can occur immediately after treatment or as long as 5 years later to be able to report occurrence of hypothyroidism. If surgery is anticipated, iodine is administered for a few weeks before the procedure. So iodine is given a few weeks before surgery to reduce both thyroid hormone release and thyroid gland vascularity. This is beneficial to decrease intraoperative blood loss. Seventh, oral iodine should be mixed with a strong taste fruit juice such as grape or punch flavors and be given through a straw. This is because oral iodine preparations are unpalatable. 9. Monitor for clients' compliance with iodine therapy. This is because compliance with iodine therapy is essential to avoid the danger of thyroid crisis after sudden discontinuation. 9th, the nurse should explain that the throat is not cut, only the skin to remove the gland. Showing children a picture of the anatomic location of the thyroid gland and the trachea is often helpful. This is to ease the fear of having one's throat cut during thyroidectomy. 10. Review need for a nutritious diet and periodic review of nutrient needs. Tell patient to avoid caffeine, red or yellow food dyes, artificial preservatives. This provides adequate nutrients to support the hypermetabolic state. A hormonal imbalance is corrected. The diet will need to be readjusted to prevent excessive weight gain. Irritants and stimulants should be limited to avoid cumulative systemic effects. Diabetes insipidus. Definition: Diabetes insipidus is the principal disorder of posterior pituitary hypofunction. This disease results in the production of large volumes of urine that leads to a state of uncontrolled diuresis. Diabetes insipidus is caused by problems with a chemical called vasopressin, AVP, which is also known as antidiuretic hormone or the ADH. The AVP fails to regulate the body's water level properly and allows too much urine to be produced and passed from the body. There are different types of diabetes insipidus. Central diabetes insipidus happens when there is damage to a person's hypothalamus or pituitary gland that causes a lesser production, storage, and release of AVP. Therefore, excessive amounts of water are lost in a large volume of urine. Nephrogenic diabetes insipidus, where the AVP is produced at sufficient levels, but the kidney does not respond to it in a normal way and continues to remove lots of fluid from the body. Dipsogenic diabetes insipidus is wherein there is a defect in the thirst mechanism that results in an abnormal increase in thirst and liquid intake that suppresses AVP secretion and increases urine output. And the last is gestational diabetes insipidus. This occurs only during pregnancy, where an enzyme made by the placenta breaks down the mother's vasopressin. Some cases are when women produce more prostaglandin, a hormone-like chemical that reduces the sensitivity of the kidney to vasopressin. Here are the different disease process for the types of diabetes insipidus. For central diabetes insipidus, it happens when damage to a person's hypothalamus or pituitary gland causes disruptions in the normal production, storage, and release of vasopressin. The disruption of vasopressin causes the kidney to remove too much fluid from the body, leading to an increased urination. For nephrogenic diabetes insipidus, it occurs when the kidney does not respond normally to vasopressin and continue to remove too much fluid from a person's bloodstream. Nephrogenic diabetes insipidus can result from inherited gene changes or mutations that prevent the kidneys from responding to vasopressin. A defect in the thirst mechanism located in a person's hypothalamus causes dipsogenic diabetes insipidus. This defect results in an abnormal increase in thirst and liquid intake that suppresses vasopressin secretion and increased urine output. The same events and condition that damage the hypothalamus or pituitary, surgery, infection, inflammation, a tumor, head injury can also damage the thirst mechanism. Gestational diabetes insipidus again occurs only during pregnancy. In some cases, an enzyme made by the placenta, a temporary organ joining mother and baby, breaks down the mother's vasopressin. In other cases, pregnant women produce more prostaglandin as mentioned before, which is a hormone-like chemical that reduces kidney sensitivity to vasopressin. Risk factors. Diabetes insipidus is more common in people with other family members who have it. Central diabetes insipidus is more common in people with anterior pituitary hormone problems. Nephrogenic diabetes insipidus is more common in people who take lithium. What happens is that lithium promotes a lack of response to ADH through inhibition of cyclic adenosine monophosphate formation, which results in patients losing the ability to reabsorb water and polyuria. Diabetes insipidus usually affects male, though women can pass the gene on to their children. Signs and symptoms. The cardinal signs are polyuria and polydipsia. So polyuria is the excessive urination. Polydipsia is the excessive thirst or excessive drinking. So for children, signs could be excessive urination accompanied by insatiable thirst, so intense that the child does little more than go to the toilet and drink fluids, and also enuresis or the repeated inability to control urination. For infants, the infant is also prone to severe dehydration, electrolyte imbalance, hyperthermia, azotemia, and potential circulatory collapse. In the infant, the initial symptom is irritability that is relieved with feedings of water but not milk. Other symptoms include vomiting, constipation, fever, irritability, sleep issues, failure to thrive, and growth problems. For the diagnostic test, it includes water deprivation test. This restricts oral fluids and observes changes in urine volume and concentration. Another is vasopressin test. This will show how the body reacts to the hormone, which helps to identify the type of diabetes insipidus. And lastly is the MRI scan. This is essential to look for secondary causes of central diabetes insipidus, such as tumor or central brain anomaly. Here are the nursing diagnoses. First is deficient fluid volume related to neurohypophyseal dysfunction as evidenced by excessive thirst. Nephrogenic diabetes insipidus is a condition in which the kidneys fail to respond to antidiuretic hormone, Both conditions mean that the kidneys are unable to retain water, leading to the passing of too much dilute urine or pale urine. Second is risk for impaired skin related to urinary frequency with high volume output and the potential for incontinence. The urea in urine turns into ammonia within minutes and is caustic to the skin. Lastly is deficient knowledge related to unfamiliarity of the disease as evidenced by request for more information. Unfamiliarity with information resources leads to deficiency of cognitive information. This could either delay treatment of client's condition or further client's complication. Managements. So under nursing management, we have the nursing interventions. First is to investigate for signs and symptoms of diabetes insipidus. This is to correctly identify the disorder and to formulate correct interventions. Second is to closely monitor the patient who has undergone head trauma. After head trauma or certain neurosurgical procedures, the development of diabetes insipidus can be anticipated. Third is to measure and record fluid intake and output. This is to ascertain that the client is replenishing enough fluid from the excessive loss of fluid. And lastly, after confirmation of the diagnosis, parents need a thorough explanation regarding the condition with the specific clarification that diabetes insipidus is different from the condition diabetes mellitus. This is to give clarity, knowledge, and guidance to the family and the client. Under medical management, the following tests are to be performed. Water deprivation test. This helps recognize the presence of diabetes insipidus. If the client has DI, the urine will be very dilute with low levels of other substances. Next is the vasopressin test. This helps to determine what type of diabetes insipidus is present. So if the dose of vasopressin stops the client peeing urine, it's likely that the condition is the result of a shortage of vasopressin. If this is the case, the client may be diagnosed with cranial diabetes insipidus. If the client continues to pee despite the dose of AVP, this suggests that there's already enough AVP in the body, but the kidneys are not responding to it. Lastly is the MRI scan. This is essential to look for secondary causes of central diabetes insipidus such as tumor or central brain anomaly. This was mentioned a while ago in the diagnostic tests discussion. For the pharmacologic intervention, administer desmopressin acetate twice daily. At bedtime to allow the child to sleep through the night, and in the morning to allow fewer interruptions in the school day. This is the pathophysiology of diabetes insipidus, the risk factors, etiology, disease process, followed by the signs and symptoms and the management, which we already discussed. So here is the nursing care plan. So for the first column, under the needs, problems, and cues, so this is considered a physiologic deficit, deficient fluid volume. The objective clues includes excessive thirst, dry oral mucous membranes, increased